Welcome to the Transforming Trauma podcast. Transforming Trauma is presented by the Complex Trauma Training Center. I'm your host, Emily Ruth, and I'm so glad you've joined us today. We're excited to share with you about an upcoming special CTTC event hosted by Roots Transition in Park City, Utah. We hope you will join us in beautiful Park City on July 19th and 20th, 2024 for a weekend of learning and connection with NARM senior trainer Brad Kammer. On Friday night, Brad will present a free introduction to NARM workshop, delivering an engaging theoretical and clinical overview of the NARM approach to healing complex trauma. On Saturday, Brad will present a NARM demonstration workshop, providing a special opportunity to observe live NARM demonstrations and gain insights into the application of NARM principles and skills. In addition to the NARM workshops, Roots will be offering wellness experiences both Friday and Saturday. Please visit our website, complextraumatrainingcenter.com/events to learn more and to register. We look forward to this special opportunity to be together in Park City and to get a direct experience of the transformation possible with NARM. If you are hearing this after July 19th, 2024, check the link in the show notes for more upcoming events and opportunities to connect. And now for our interview. Dr. Karen Maroda is a psychologist and board-certified psychoanalyst in private practice in Milwaukee, Wisconsin. She is also an assistant professor of psychiatry at the Medical College of Wisconsin and sits on the editorial boards of the Journal of the American Psychoanalytic Association, Psychoanalytic Psychology, and Contemporary Psychoanalysis. The author of numerous journal articles and 4 books, Dr. Maroda's most recent titled The Analyst Vulnerability, Impact on Theory and Practice, has received wide recognition across theoretical originations because it focuses on the early childhood experiences of all psychotherapists. I hope you enjoyed this conversation with Dr. Karen Maroda. I'd like to welcome Dr. Karen Maroda. Welcome to Transforming Trauma.
Thank you. Nice to be here, Emily.
Yeah, great to have you. And how we usually start this conversation is with me just asking you, what would you like our listeners to get out of our interview today?
Well, I think especially for the people who are not familiar with my work, but probably even as a recapitulation for those who have been following my work for the last 4 decades or so, is that the threads that go through most of my work are emphasis on the countertransference, all the emotions that are stimulated within the therapist or analyst during the treatment. And then more importantly, I think this is a much neglected area because I think for many decades now, people have recognized the importance of the analyst as a person, right? Or the therapist as a person. Going back to from when I was a graduate student and I was so impressed with Harold Searles, who was a famous analyst at the time. Sadly, many people now don't even know who he was, but he wrote about his intense feelings in response to his patients. But he worked mostly in inpatient setting, the lodge. So he was dealing with a lot of schizophrenics and severe borderline personality disorders. And so he was free to write about his dealings with them, including his self-disclosure of his affects, and get that published because he wasn't seeing outpatients. Oh. Nowhere at that time, like in the 50s, 60s, early 70s, was it considered acceptable to disclose personal feelings in response to a patient. And he actually wrote a very nice review for my first book that I wrote in 1991, which was The Power of Countertransference. And I had the distinct pleasure of speaking to him at length on the phone. He's a very generous, kind man, and wrote a lovely review. And I said, Dr. Searles, your work has impacted me so profoundly. And I understand that some of the patients that you treat are, of course, intensely provocative. And you have these really intense responses to them. But it seems to me a modified version of that occurs in every treatment, that we're all mutually affecting each other emotionally, and that psychoanalysis doesn't address that really. And I don't think any form of treatment, because behaviorism was just really getting going then. It's kind of like, as a quick digression, psychoanalysis is to therapy, for a lot of people who don't know that, young therapists, what Catholicism was to religion. Protestant religions didn't exist. They were spinoffs of Catholicism. And that's pretty much true for therapy. I mean, Freud is widely recognized as kind of the creator of a really interactive, verbal, limited regular meeting for discussion of emotional problems. And so everything that followed after psychoanalysis was a reaction to psychoanalysis, to its limitations, to its demands. And behaviorism grew out of psychoanalysis, as have all other forms, in some way. So psychoanalysis set the standard, and in many ways that was fabulous because it was very deep, went super deep, acknowledged intense primitive affects. And I think to this day has a broader and deeper theory and approach to treatment than I would say than many others do. Although I also say too that you have to give behaviorism its credit, and I was trained in behavioral techniques and use them regularly and incorporate them because what behaviorism understood and recognized and utilized was what Crystal says. It's Krystal, Henry Crystal. He said all emotional disturbances are exactly that. They're disturbances in emotion. And we used to say people have emotional problems because I think he makes a very cogent argument for the fact that if you think about all the diagnoses, they all involve, from its anxiety to dissociation to whatever you're talking about, they all involve affect regulation. There's a problem there. And to some extent, of course, we all have some degree of issues with that. No one develops perfectly, but that all the major diagnoses relate to affect regulation. So most of our patients, whether they're what we used to call garden variety neurotics or severely traumatized dissociative people, what they share in common is some defect in the capacity for knowing their feelings, expressing their feelings, regulating their feelings, deciding when and how to express them, and accepting them without shame.
That right there is what I feel like that's the rub right there for a lot of us, accepting them without shame. Yeah.
Fast forwarding to the present and my most recent book, which is The Analyst's Vulnerability, it turns out from at least my clinical experience treating many therapists and supervising many therapists, particularly in the last 10 years, when you get to be a senior published person and, you're sought out by many therapists. Earlier in my career, I was just treating a general population. But I started to observe that therapists have a commonality in their early experiences. And not psychoanalysts, but all therapists have this history of being a parentified child that results in conflict avoidance to some extent for most. Again, these are generalizations and it varies, but most therapists have problems with feeling too responsible for their patients, too responsible for loved ones, state of mind, period. Starting with taking care of depressed mothers or ill people in the family. I've treated some therapists who maybe just had to tend to a somewhat depressed mother, to people who were in charge of every person in the family and maintaining the emotional equilibrium in the family, including the parents' sex life. Yeah. I mean, really, just terribly burdensome tasks for children.
Yeah.
And I talk about how we were chosen for that role because we were naturally empathic and sensitive. So what is also our strengths, as Searles would say, is in that guilt-induced, it doesn't just determine our vocational choice. I argue in The Analyst's Vulnerability that it determines our choice of theory and how we practice. But this is largely not noted, not discussed, not even within the therapist's awareness. And that it gets, even when you go for your own treatment, as analysts must, and as I did, of course, I did 5 years of psychoanalysis, your analyst or therapist is most likely to have those same dynamics and is going to pass them on to you.
Yeah. Like a generational.
Yes, it's a generational, not transmission of trauma per se. It's a generational transmission of what our role is, what's permissible, what's okay to feel, what isn't okay to feel. And so this guilt-based, approach to other people gets carried on from generation to generation. So I went to go back to where I started, I went as a young therapist from being so impressed with Searles. And again, back to our phone conversation, asking him, Dr. Searles, why, your thoughts about affect and the affective exchange and how powerful it can be in the room. Why do you not talk about it and generalize to, I know you do outpatient work as well. Why are you not speaking to people doing outpatient work? And he said, because if I did, I would never get published.
What a shame.
I know. And I know that to be true because for years I could not get my work on countertransference published.
Mm.
And in some quarters, I still have trouble getting published, even though I'm a very well-known psychoanalyst, because there's such resistance to hearing certain ideas. And the people on editorial boards tend to often be senior, more conservative people.
Yeah.
I always tell people, if you want to be heard, it's easier to get a book published than it is to get a journal article if you're doing something innovative.
Yeah.
And in fact, I was at a meeting presenting a paper on countertransference, and there was an editor in the audience from John Wiley and Sons who approached me right after and offered me a book contract. And that was the start of my publishing.
Really?
Career. It was writing my first book. Yeah.
Mm.
And in that book, I even discuss how to approach the feelings that we are often ashamed of, like feeling angry, resentful, envious. And talking with therapists, we are mostly aware of these feelings as human beings, but we don't know what to do with them in the session. That's the problem.
Yes. Yeah. You're making me think of a story. Is it okay if I share really quick?
Oh, by all means. By all means. Yes. Go ahead.
So
Emily.
I knew I was really drawn to working with certain clients. I had facilitated some like non-therapeutic support groups before going back to grad school. And I noticed that I had, thoughts and feelings coming up for me when I was sitting with folks when I facilitated these groups. And I had done some years of my own therapy, and it just never occurred to me that my therapist may have thoughts or feelings about what I was bringing in. I didn't hear anyone talking about that yet. Maybe I didn't even know the word for countertransference yet. So very early on in my learning, I was like sitting in this training with about 200 other people. And I just asked this question about, what do you do with these feelings when I remembered coming up in those groups? And the teacher very sternly told me that I shouldn't even begin to think about working with clients that I had any feelings about or connection with. I think her phrase was, if I remember it right, that I was right in the water drowning with them if I did have any feelings coming up. And I didn't think I'd been drowning. I was just like tracking, things that were coming up.
And feeling and alive.
And feeling and like being a human, right? And so in that moment, I started like shaming myself for what I obviously later learned was very normal. I was told to essentially shut it down, which I obviously couldn't do. But so, you're just reminding me of like, that was some of my earliest learning of like, no, shut it down. You're not allowed to have any of these feelings. That's like shameful.
Right. And I'm sure you can see too, that trying to navigate your feelings in the treatment without any instruction from in your training, because we can't just like blurt out everything we're feeling. So how do we decide? That's a huge issue. Like in disclosure. And I also like present on ethics and disclosure, self-disclosure, because how do you do it? How do you do it well? How do you do it ethically? How do you do it without the, much feared issue of disturbing the flow, of the patient's narrative and making your feelings more important than the patient's. Right? So obviously none of us want to do that. So then what do we do?
Yeah.
How do we disclose? When do we disclose? What type of disclosures are more effective than others? And there is really quite a literature on this that is often ignored. But I want to ask you a question. You're pretty young. How many years ago was this where you were told to shut down your feelings?
This was about 10 years ago.
Yeah.
And thankfully I've had much better trainings. Well, in my, how I hold it, I feel like I've gotten much more training around what to do when those things come up for me. But gosh, if that had been my only, if I had shut it down and hadn't asked any questions or sought out different training, I would be a very different therapist than I am right now.
Sure. And as Cyril said, our sensitivity, our emotional sensitivity and natural empathy, that's our greatest strength. But it can also be our greatest weakness if we don't know what to do with it.
Yeah. Right?
But we need to tap into it and see it. I think he said it's the wellspring of our, and it is. It's how we were tapped originally as children to be the emotional caregivers. And it's a talent, actually, that we bring. It's a strength. But, and it's a shame that we've never learned how to use that strength productively. And I would have to say that's generally still true. And that people are reluctant. They fall into the camps of either very reluctant to express their feelings to oversharing.
Mm-hmm.
In fact, I've been chagrined to hear people say, "Oh, Dr. Maroda, I love your work. I've read all your work." And I just say whatever, whatever I'm feeling
Oh, no.
strongly as a result of reading your work. And I think, oh, no.
You're like, did you finish the book? Did you?
Yeah, exactly. Did you read all the stuff about don't do that? But
Yeah.
it's interesting how people will
Interpret.
read in or hear what they want.
Mm-hmm. Yeah.
And I think that position put me at odds too with my contemporaries on self-disclosure, which are Owen Rennick. I don't know if you've heard of him, psychoanalyst, and Darlene Ehrenberg. They talk about a more spontaneous use of self-disclosure, and that's more intuitive. Rennick talks about shooting from the hip or playing with your cards face up and just being really open and expressive throughout the treatment. And I really don't favor that. I think it has to be more well thought out. And I think it can easily fall into kind of a mutual treatment rather than so that it might have its gratifications and some benefits. I don't think it offers as much benefit, and it offers a greater opportunity for harm if we're not consciously aware of what we're doing. And, I always say, regardless of the intervention, if you don't know why you're saying it and you don't know what to expect from the patient, how they're going to react, why are you doing it?
Yeah. Well, that brings up not really a question. Maybe I'm just putting out there your book, The Analyst Vulnerability, where you talk about, as a clinician, there's this need. Well, maybe some folks are feeling this need to deny what they're really seeking from the analytic process. Can you talk a little bit about that when there's a blind spot with the therapist and we're not aware of what is it that we're coming to this space with? Does that question make sense?
Yeah, I think I know where you're wanting me to go, but you can let me know if this doesn't cover it. But yeah, I think that the other big source of denial in our profession is how gratifying this work is. There's a tendency for us to actually, valorize being a martyr,
right?
And being enormously self-sacrifice. We portray ourselves often, and we think about ourselves as martyrs. But I have another thought about that. That's because we were martyred as children.
Mm-hmm.
The parentified child has been martyred because you've been robbed of some of your childhood and burdened with the responsibilities that you were too young to have. That was true of me. And I have some people say, I don't know what you're talking about. That didn't happen to me, but
bless them.
Yes. They're usually psychiatrists, by the way.
Oh, interesting.
Yeah. Social workers and psychologists will say, oh, yeah, I was definitely the family caregiver. But psychiatrists tend to say, oh, no, I don't think so.
Oh, interesting.
Or I'm not aware of that.
Okay.
In my little, this is informal polling, by the way. There's nothing scientific about this, sampling. But for the most part, people will say, oh, yes, definitely.
Mm-hmm.
But there was gratification. Even, I think there's a reluctance to deny gratification, even if you root it back to our childhood experiences, because there was some guilt too. Actually, a colleague of mine, Brian Smothers at Milwaukee, pointed this out to me. He said, don't you think that one of the gratifications is that we feel special? That we're very special and important in the world of the people we treat. And the longer you treat them and more in depth, as in a psychoanalytic or a psychodynamic treatment, often the more special you are, the deeper the emotional experience between you. So not only do we get vicarious, gratification from their emotions and all the emotions that they stimulate in us that we want because we're emotional people. And do we get to have the satisfaction of all this intimacy with all these different people from all walks of life and occupations? I mean, I can't even begin to enumerate all that I've learned from my patients over decades of doing this work. And when I say learned, I mean too emotionally changed as well.
Right.
Transformed by them, but not with that as the intent. It's a natural byproduct, I think, of a healthy, mutual, relationship. Mutual in terms of affect, but asymmetrical in terms of execution. Right.
Yeah.
So I think that there was guilt because we were often like the favorite child or the special child. I found in my family, and I've just begun to explore this with other therapists, there's often a great deal of sibling rivalry with the therapist child.
Yes.
The therapist child was the special one who could do things the others couldn't. That often results in intense, sibling rivalry and ambivalence in the sibling relationships. And also too, Freud would say Oedipal, but, often there was jealousy. I've treated therapists who, were more aligned with the father and the mother was jealous, and more aligned with the mother and taking care of her, and the father was jealous. So that parentified child kind of disturbs the natural, what I would call like a more natural flow of dynamics within the family, and sets up a lot of power issues. So we tend to deny power. Power is a dirty word for therapists. We don't have any power. We're just being so really nice, self-sacrificing us, doing good in the world.
Gosh. Yeah.
But see, then too, we also naturally developed ambivalence toward our parents, toward some of our siblings. And then there's guilt. Searle says there's guilt about that. And so then there's all this guilt and ambivalence. And if you don't get in touch with that, if you don't get in touch with, I loved my mother dearly, but in adolescence, I became aware that this was not reasonable for me to be in charge of her mental health.
Yeah.
I was fortunate. I think I got a great deal from her. Unlike some therapists who had, very remote, inaccessible, or take to their bed depressed mothers. My mother was very active every day, very, very warm, very expressive, encouraged my siblings and I to be emotionally expressive, which I think is at the heart of my what I have to offer people. I wasn't shut down.
Yeah.
I was guilted into doing things I didn't want to do.
Yeah.
But I could say I didn't like it.
Oh, that's interesting. There's like duality there.
Yeah, especially in adolescence when I started acting out. My mother, she had probably too much tolerance for that, I would have to say. But I got a lot of warmth and nurturing from her, as well as being the parentified child. So there's a tendency to deny the gratification that we deny, the power that we had, and feel a lot of guilt and shame about that, that we carry into doing treatment. So then we say, oh, no, we don't get anything from our patients. And God forbid we would get something from them. Now, to me, that's crazy. Why would you say that about any ongoing relationship? That you choose to be in a relationship with this person and work with them for months, years, and that you would say you got nothing from that person? And that doing this work day to day, you get very little or nothing personally? Why would anyone choose a vocation, especially one that requires a high level of training and intellect? Why would you put yourself in that position? We don't.
If you weren't getting anything.
If you weren't getting anything. Yeah. In fact, one of the pieces of advice I give to young therapists is, one, don't treat anyone you don't like. That will never go well. And when I say don't like, I don't mean that you think everything they do is great. I mean, many, if not most of the people who come to us are saying they're doing things they know aren't good. Or that they have issues with anger or whatever. And often they're not likable in every way. So I'm not saying you have to have this unconditional. I don't even believe in unconditional positive regard. When people say they're looking for that, I say, then get a dog. Get a dog.
You're like, I'll refer you out.
Get a dog. And so, but I think that we have to find that person interesting, feel ourselves in kind of engaging, being thoughtful, being stimulated somewhat by the person, and thinking, yeah, I could help that. I think I could help that person. But if you're turned off, you're not interested in them, you don't particularly like them, that's a person that you should refer out. And I've talked about that at length, because that emotional engagement, and that's one of my specialty areas, that emotional engagement is at the heart of change. And if you can't be emotionally engaged with the person you're treating across time, you can't treat them successfully.
Yeah.
So if you're feeling too little, and I guess you could also argue if you feel too much. Also, if someone stimulates immediately a lot of fear or eroticism or desire to flee, that's probably a person you shouldn't be treating either.
Yeah, and I'm thinking about how, if I had someone walk in my door and I noticed that was coming up, I would imagine I'd probably want to do some work around that. I get curious about why it was evoking so much, intensely.
I think strong feelings are okay, but not ones that you find you can't contain.
Yeah.
Especially very early on,
Yeah. I've read that you favor an approach that really focuses on feedback and confrontation. And I imagine in order to hold that, you would have to like genuinely like the person. Am I wrong on that?
I know. I don't think you're wrong at all. I think that the constructive confrontation comes from a space of being respectful, engaged. I don't think it's possible to confront someone well if you're not sufficiently aware of them and how to speak to them and concerned about them.
Yeah. Like they would feel the roots of, like, if you didn't have that genuine, like, respect and care for them, that then when you're confronting or you're giving them some feedback, they would sense the root of it wasn't that genuine care.
Yeah, I think that's an excellent point, Emily, is that, yes, people know whether you care about them or not.
Yeah.
And they know when you're being punitive or just being critical or judgmental. And again, we all do that at times. What I say is the thing we have to offer our patients, the main thing we have to offer them, I think, potentially, no matter what the setting, is that not that we're not going to, psychoanalysis used to say we have to white knuckle it and don't show or express any strong feelings we're having in a relation to a patient. Because if we do that, we're going to be repeating the past with them. Mm-hmm. We're going to be repeating a pathological scenario. And that was the basis for the supposedly neutral, blank slate analyst who would not reveal themselves. But that's clearly not humanly possible. But more importantly, it's not therapeutic. Mm-hmm. It's definitely, and even though the analytic literature is filled with case reports from decades ago of people highlighting their abstinence and neutrality, if you talk to analysts, which I did, generations older than myself when I was young, the nice people didn't really do that. A number of analysts, older analysts, have confided in me that what they did is when they wrote up their cases, they made them conform, again, like Searles, they made them conform to what was expected so that they would be respected and published.
Yeah.
Because what's the likelihood that all analysts could have actually been like that as human beings?
Yeah.
I mean, they couldn't.
Not very likely.
No, there were some people, some sadists who were, or people were afraid of their own feelings, but nobody would have ever gotten better in an analysis if people actually worked that way.
Yeah. Yeah. Just, I imagine it. I'm like, that'd be sitting in front of a robot. That doesn't feel like it would be helpful.
No. So, yeah, I like to research things. I started out, again, back to early in my career. I went into analysis soon after I started practicing, both at a university and started a little private practice on the side. And then I live in Milwaukee. I started commuting to Chicago to see a training analyst there. And I'm an emotional person, as you can probably sense from talking to me. And I like being an emotional person. And my patients, too, could see emotion on my face because I'm really not very good at hiding it. So even when I was barely silent, they could see it in my eyes, in my facial expression. And I noticed over time that even though I bonded very quickly and easily with most of my patients and liked them, and we had a flow, things were happening, we would inevitably reach points where they were extremely frustrated because they were needing a response from me. They wanted to know how I saw them. They wanted to know what I thought at certain times. And most importantly, they wanted to know what I was feeling when they were picking something up. And they wanted that validated. And at the same time, I'm going to analysis 5 times a week in Chicago. And I'm, of course, as a therapist, hypervigilant and attuned to my analyst and her feelings. And as I got to know her, I could sense, all the nuance, the differences, like how her mood changed from day to day, not dramatically, but I noticed subtle changes. I could hear it even when I was on the couch, which was most of the time. I could hear it in her vocal tone. And I knew when she was off or not really listening, not with me. And I would stop.
Interesting.
And I would say, Dr. So-and-so, I say, you're not with me today. What's going on? I know that was so verboten, Emily. I cannot tell you how shocked she was at this point in time. This was completely unacceptable. This is the 1980s. It was so unacceptable. You have no idea. And it was like, what? She looked at me like, what are you doing? You know the rules. You know I'm not supposed to answer. She didn't say that, but she might as well have. Mm-hmm. And I said, I said, I'm not so narcissistic that I can just go on blathering about myself and my inner world, knowing you're not really there. And I don't need to know what's bothering you or what's on your mind, but I need some affirmation that you're off today and that maybe some hope that we could re-engage. And she was stunned by that, but it actually made sense to her. So then she would tell me, and this is something that many analytic people have discussed subsequently, and I think probably prior to me, is that just the act of that conversation would open things up. I didn't need to know what was bothering her. I didn't need to know if she had a fight with her husband that morning, or one of her kids. I didn't need to know any of that. I just needed her to affirm what was going on between us in that moment.
Yeah.
And then I started doing that with my patients in a very limited way and experimenting with it. And just light bulbs just kept going off every time with me, with my analyst, with all my patients. And I thought, Eureka, I don't know how to do this well yet. I don't know where I'm going. I don't have a full understanding of what's going on, but I do know that my patients need to hear from me in relation to them, and that I need to hear from my analyst in the same way.
Yeah, I'm just appreciating, how that humanized you, I imagine, for your patients. Like, she's a human too. She's not this robot in front of me. And that, like you're saying, it was a limited, it's not like you were sharing everything, but just acknowledging I'm a human, we're humans in this room together. Like, what a beautiful, connection point.
Yeah. And I think too, it's very empowering. I also write about that. It's empowering for both patient and therapist to be able to connect in that way. And one of the things I've learned from doing research on affect and in neuroscience is that it would appear that there's more research that needs to be done on this, that affects have an influential purpose. It's not just about self-expression. It's about power and influence, because that's how you make your way in the world. And that's one of the things I started to observe. The more I ignored a person who needed to impact me emotionally, the more they came at me. And that's especially obvious in people who have borderline personality disorder. I think the main reason most people with that diagnosis often did not get treatment or had a failed treatment or a truncated treatment is because the patient's banging at the door, wanting an emotional response, and perhaps some limit setting within that as well. And if they don't get that affective response and they just they're pushing because they need something, that's something that they didn't get from their parents. So rather than, I think, the love cure, which I'm not big on, even though I love probably many of my patients and like all of them and care about them deeply, I don't think what I have to offer is that I love them. I think that's a nice benefit. It enhances the relationship, I think, but I don't think it's at the heart of what therapy is. I think what's at the heart of therapy is that recognition of the other and their reality and allowing for and acknowledging that mutual influence through emotion. So over time, as I was treating people with borderline personality disorder, I discovered that I was frustrating them to death by not responding, by letting them criticize me, plead with me. People will, again, openly talk about, among other therapists, oh, these patients drive me crazy. I can't stand them. I start to dread seeing them. Oh, we're in another impasse. And again, just from closely observing, I began to realize that these intense emotional scenarios that occur sometimes with, patients who are really disordered in terms of affect is they keep coming back at you because I think it's admirable that they're not going to give up. They're going to keep trying to get that response. And it's so misguided to think that we're supposed to be martyrs and masochists and just accept getting beaten up, criticized, told that the treatment's no good, it's not going anywhere, and just berated, that is not therapeutic at all. It doesn't help that person. That person, I would say the hard job of being a therapist is confrontation, is giving that feedback. That's much more difficult than sitting by passively. And sitting and being passive we learned again in our families of origin because we didn't have insight at the ages we were tabbed. We had no power other than to please and to provide what was asked from us. So that carries over too. I think therapists are way too passive and conflict avoidant. And conflict's at the heart of change and negotiating conflict, right? In every relationship.
Right. Yeah, something I was thinking as you were talking about that, and these therapists are like, "Oh, this client that they're doing this, or we're stuck. I'm stuck with them. They're resistant. All those kinds of things." I'm like, how would the client not pick up on that the therapist is feeling that? Like, there's got to be some. So they're the client's kind of coming at them. I'm holding that like. They're not responding, or how did you describe that the therapist like just wasn't responding to them? These clients are kind of coming at them and they're just not responding. How did you say that?
Yeah. They're not responding. They're being passive and just being masochistically allowing it to go on, or even empathizing with the anger, but then,
not doing,
which often just fuels it.
Mm-hmm.
Right. And the other thing too is it's not as though all the research we know on affect says the patient knows what we're feeling.
Right. That's like, they're picking up on that. You may not be like saying it, but so they're coming at with this energy of not only are you not responding to me. I mean, I'm just thinking of how objectifying that sounds when therapists are saying those kinds of things about clients, but they're not naming what they're feeling inside. And so it just feels like there's this objectification that's happening. But anyway, I'm really appreciating how you're talking about this.
And I think too, there's a misguided belief that the therapist's anger will be destructive.
Right. Yeah.
And that again stems, I think, from the guilt and shame of being angry at the parents, and wanting to strike back and wanting out of the parentified child and the fear of losing the parent if they do that. Like when I talk to, I used to love going out on the road, as we say, when after I write a book, I really miss that this time with my latest book, because there's still this pandemic, carryover of not meeting in person.
Mm-hmm.
I used to fly all over the country or the world and, meet a lot of people and talk to them. And so I miss that, but I get some of that and I do Zoom instead, so I've done a lot of speaking engagements, but I think only one in person, which is a shame. But anyway, therapists, when they would come to me like on breaks, from a workshop or a conference, they come up to me and say, I've got this client or this patient and I'm just really stuck. We've been at an impasse. And of course, the journal articles are filled with discussions of impasse and enactment.
Right.
And we're just not going anywhere. And I just kind of dread the person coming, and there's either no engagement or there's this unspoken hostility. What should I do? And I'd say, well, what's exactly happening? I always go, give me exactly what's happening. Like, think about the last session. What was your interaction? And then I hone in on that. I say, okay, so when the client said this, you were feeling understandably irritated. What would you think about saying something? Like, even sometimes if somebody's hostile toward me, especially if I have a good relationship with them, I like to use humor. Sometimes I'll just go, ouch.
Just name it.
Yeah, it's ouch.
Yeah.
And they'll be kind of taken aback by that. And then like, oh, wow. Yeah, that was kind of nasty, wasn't it? And I say, yeah, pretty much. Or once I said to a patient who wanted me to, give in on something that I wasn't going to give in on, and just kept coming at me. And I said, do you really think you're going to insult me into submission? Do you think that's a good strategy? Because I don't think so. And then like a light bulb went on for her, and we had, a good conversation about that. But back to what happens when I try to work with people just in the moment. I think I'm very heartened by how successfully I can work with people weekly in terms of supervision and consultation. But in these brief, at a conference type, quick consult. And I said, well, what if you said to the client, I find that really insulting or irritating, or I don't like being talked to that way. They say, oh my God, I couldn't say that. Or even simple things like fees. I'm really getting angry at this patient and I don't want to work with them because he owes me $5,000 or $7,000 and keeps saying they're going to pay me, but they don't. I said, well, what if you asked for payment and said, we need to discuss this. This is a clinical issue. When someone doesn't pay you over time, it's not just a financial issue, it's a clinical issue.
Yeah.
And often those people are the same people who don't pay their bills elsewhere as well and don't manage their finances. So across the board, it's a clinical issue.
Yeah.
That you're not taking responsibility for addressing. So Even something as simple as that, oh, I couldn't do that. And I say, well, why not? And they say, because, oh, they would get angry, I think, or they would feel hurt. I would hurt them. Or again, and I write in the Analyst vulnerability about this excessive fear we have of doing harm because of our repressed hostility. And they say, oh, that would really hurt them. Or they might leave, or they might become suicidal. So, when you described this client to me, that there was no mention of suicidal. Was this person suicidal ever? And no, but they might become suicidal.
If they had to pay their $5,000.
Yeah, if they have to pay their $5,000, they might want to kill themselves. It's like, as you can see, I mean, that makes no sense. But I think, with all due respect to these people, it's fear-based. I think many of our decisions are fear-based rather than good clinical decisions, thought out decisions, and in the best interest of the client.
Well, and one of the things that it sounds like you're highlighting is these patterns that they have with you are the very patterns that they have in their lives that they're struggling with. That's why they're coming to you, to help them change these patterns.
Absolutely. And the advice I give when you're having strong feelings toward a client is, of course, you don't just immediately start talking about your feelings. The whole idea is it'll come up again and again. And if there's some kind of dynamic happening, you don't have to address it immediately in that session that you feel it. If you're not feeling like you understand it, you don't understand what's your part in it, what's your history, what's being tapped into, or what's the client's, just go home and think about it. You don't, or talk about it with the colleague. You don't have to make a decision right then. Anything that's important will keep recurring.
You can kind of bookmark it and plan that it'll come up again.
And as you pointed out, Emily, one of the most important things to think about is this the pattern that person has in the world? And to me, it's inconceivable that someone comes in and says themselves, I can't maintain relationships because I get angry at people and then they leave me. And then the same thing happens, but they won't confront me or anything. They just leave. They either just cut me off. And that's true in our culture too. People's, bad behavior is rarely addressed directly in any way, form of our life and our culture. And so that's why it's even more important that we as therapists be able to address those things. If we're afraid to address them, we can't help our clients. But see, this also, segues into the whole issue of diagnosis, which has now become it's out of favor, for lack of a better phrase. The diagnosis is pejorative, it's objectifying, but you have to have some way of hearing what the client's saying about their repetitive patterns, understanding those, putting them in a framework of understanding, and coming up with a treatment plan to address that. And you can use any name you want. If you don't want to use borderline personality disorder, you can say pervasive relational disturbance and rage problems, but you have to. We name things so we can process them. If you stop naming everything, then everything just turns to mush.
Yeah. Well, something else that just came up for me as you were talking about that, I read this thing online. This woman was saying, I ghosted my therapist like 2 years ago. Like we started getting really close to what was really the problem. And I was so afraid of it. I ghosted her. She reached out. I had never responded. She's like, a year later, I was ready. And I went back to her and she was, the therapist is like, okay, you're here. Let's get back to it. And I that stuck with me of like, okay, how interesting. This client recognized that she was avoiding what they were getting closer to. And when she was ready, she went back and I sort of put myself in the therapist's shoes like, okay, so what is a therapy, when that happens or if that happens, are we solid enough in our own selves and the work that we're doing that if or when a client ghosts, can we hold our own emotions around that? I don't know if that makes sense or if that feels relevant to you.
There's no sense of wanting to retaliate against that person. But I think ghosting is inherently upsetting I will say I have had people who reached that limit where they couldn't go any further. It was too, I think we all have, but I've never been ghosted and I really wouldn't like that.
It'd be hard. Yeah.
I kind of like to take pride in the fact that people can tell me. I think you can do a lot to avoid ghosting from day one, I encourage my clients to feel free to give me feedback on what I'm doing. I emphasize that therapy is a collaborative process. and that it's important that all the feelings that they're having that they're not managing out in the world, they're going to have with me eventually, and that they should feel free to say anything positive, negative, whatever they're feeling.
Yeah. I think that's why that came up for me, because I had read in your work something that you sort of name that right in the beginning, and how useful that is, just like what you're saying, that it normalizes, hey, everything that you have in your life, that will probably come up here. That's kind of the purpose. We want to be able to look at it, and I want you to feel like this is a safe enough place for you to bring those things up so that we can, be curious about them. And I appreciated that.
Yeah, thank you. That's exactly what I mean. Yeah. But I think too, another obstacle for therapists to express their anger is that anger ratchets up pretty quickly, and particularly if you sit on it then for days, weeks, months. By the time a therapist, even thinks about expressing it, they're so enraged they just want to like strangle the client.
Gets intense.
It becomes inconceivable to find a constructive way to express it.
Mm-hmm.
And I think that's a lot of the avoidance, even with people who think it's a good idea, or it could possibly be a good idea to express it. They say, I just don't know how I would do that though. I've never been taught how to do it. And I'm certainly not going to unleash my rage, my murderous rage on this person. and of course they're correct in that. Yeah. Mm-hmm. But the trick is to catch it, is to be aware and accepting that rage is permissible, not to stuff it down. I always say, be curious about everything that's happening. If you suddenly feel like you have fantasy of hitting a client, or shoving them out the window, or screaming at them to get out and never come back, or wanting to, have sex with them, whatever it is, be curious. That's the path to, understanding and communication rather than withdrawal.
Yeah. And you're naming, I think what I'm hearing you say is like the earlier on that we can be curious about it and look at that in ourselves, it won't shift from emotion into behavior, right? We're looking at it before it's actually a behavior. We're looking at early on.
And especially any destructive behavior, which I understand the concern, but I think it's an overblown concern based on guilt and sitting on anger for too long.
Yeah. I appreciate that. Well, I'm mindful of our time. I know that you've got to get going here, but I wondered if you could share with us, do you have, any experiences in working with clients or even in your own personal experience that you feel might be supportive of our listeners' learning?
Well, I recalled this, case in the stories many times, but perhaps people in this audience would not have heard it. It was my first big experiment with countertransference anger. I had a patient severely traumatized. Mother was extremely unstable, drove her husband away with her. She was a severe borderline personality disorder. My patient, severe borderline personality disorder. And you could just feel the anger, the energy pouring off of her when from the first time she came to see me. I initially thought, boy, this person's going to be a handful. And she was. So why did I want to treat her? Because she told me that she had a little girl, and that little girl was now like 5 years old and had reached the age where she was saying, no, I don't want to do that, blah, 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 blah. And she caught herself raising her hand up to slap that kid across the room the way her mother did to her. And she said, I came here because I don't ever want to do that to her. And I know I'm going to. I know, it's heart-wrenching, isn't it?
Wow. Yeah.
And I'm not a big fan of all really super dramatic case reports, just to be clear about this. But this moved me so much. That's why I wanted to work with her. I thought, boy, this is so admirable. She is not going to do to someone else what was done to her. And then on top of that, the mother finally remarried, and the stepfather sexually abused her for years. So she came by her rage, honestly, as we like to say. But boy, she was a handful. And she wanted me to be her mother. She wanted me to be her lover. She wanted me to be her best friend, to be that, object that she never had, that person. And so I expected that. I was ready for a lot of that, but it just intensified over time. And she said, you're not helping me. This treatment isn't any good. If only you would love me. And then she'd say, like, you just don't care. She would just berate me, plead with me, beg with me, and put this pressure on me. And I saw her twice a week at a reduced fee. And I just started to feel like my stomach started churning when I knew it was her appointment time. And I thought, I have got to do something about this. And I got consultation. I did all the, right things. I just gave her empathy about it. Of course, you want what you never had. It's, it seems so tragic that your childhood was stolen from you and you didn't get this maternal love you needed. That would hold her for like 5 minutes or maybe the rest of that session.
Mm-hmm.
Then a few weeks later, she'd come back. We'd start over again.
Yeah.
And no amount of advice. And that's where I started to formulate the idea that the person you really need to consult is the patient often on these, not another therapist. You can talk to another therapist and it's helpful in terms of sorting out your own stuff. But ultimately, you have to do it in the relationship with the client. So I started thinking about all this affect as influence. She says she's trying to get me to love her. But what am I feeling? No love, not love. I feel pressured. I feel aggressed against. I feel violated. I feel bullied. I feel, all these things. I feel hated. And I was starting to hate her. So again, with stomach churning, this was my first big time of trying this. But I thought, I've got nothing to lose. This can't go on. And I just said to her when she did this, I said, I don't feel loved at all. This is not love. I think you hate me. And I'm starting to hate you because I feel like you've got me by the throat up against the wall. And her immediate response was fear that I was going to abandon her, right? And I said, no, that's not what this is. I'm trying to work this out with you. I'm trying to tell you how I feel.
Mm-hmm.
And then she calmed down immediately. She sat there for a while and I thought, what is she going to say? What's going on? And I finally said to her, what's going on? And she said, well, I don't want to be, I know I'm kind of nasty, but I just want to say, we've been through this so many times. Why didn't you tell me this before?
Oh,
wow. I was so relieved. And I said,
like,
oh my God, really? And she said, yeah. And I said, well, so you understand? She said, yeah. And I said, well, then why don't you just tell me how angry you are that you can't get what you need from me instead of the false love, And she said, because if I ever told my mother I was angry or hated her, she would slap me across the room so hard and then she wouldn't talk to me for days.
Oh.
So that's why. But I said, well, you don't think that when you're doing it though. She said, no, but if I stop and calmly think about it now, that's why.
That's why.
And it made a huge change. It's probably the most dramatic moment that I ever had and most impactful in my entire career. And it was in my first few years of being a therapist.
Wow.
But you can see how compelling that was. What a compelling argument that was, which she couldn't get. It was, yes, she couldn't get love, but I can't give her that. I couldn't be her mother. Mm-hmm. What I could give her was acknowledging her feelings and discussing them with her and talking about my feelings and negotiating that moment. That's what's therapeutic that we have to offer.
Thank you so much for sharing that. I just want to let you know I really appreciate all that you've shared with our audience. And where can folks contact you and get a hold of your work? You have books out, you've got a website. Tell us all the things.
Yeah, I have a website and all my books are listed. I have 3 books with Routledge, Power of Countertransference, Seduction, Surrender, and Transformation. And the latest, The Analyst, Vulnerability. And in between, I decided to write a book for therapists in training. And that book is with Guilford, and that's called Psychodynamic Techniques, Working with Emotion in the Therapeutic Relationship. And it's been popular as a text for early career people and the people who teach them, of course.
Fantastic. Thank you so much, Karen.
Okay, thank you, Emily.
Thanks so much for joining us for today's episode. To find more information about our guest, check the show notes or visit us at complextraumatrainingcenter.com/transforming trauma. You can also connect with us in other ways. We're on Instagram, Facebook, and YouTube. We hope you're as excited as we are about the upcoming NARM event in Park City, Utah. Mark your calendars for July 19th and 20th, 2024, and join us for a weekend of learning and connection with NARM Senior Trainer Brad Kammer. We invite you to encounter NARM directly and deepen your experience of this revolutionary approach to healing. Reach out to us at admin@complextraumatrainingcenter.com with any questions, or visit complextraumatrainingcenter.com/events to register. We look forward to seeing you in July in Park City. If you are hearing this after July 19th, 2024, check the link in the show notes for more upcoming events and opportunities to connect. The Complex Trauma Training Center emphasizes professional development in support of personal growth. We provide clinical trainings, online webinars, ongoing consult groups, mentorship programs, and community events. Our mission is to provide a relational, inclusive, and depth-oriented professional community for those seeking a supportive network of therapists working with complex trauma. To learn more about our trainings, programs, and events, please visit us on our website at complextraumatrainingcenter.com. Thanks to Andrea Klunder and the Creative Imposter Studios for producing and editing, to Elisa Sponseller for our album art, and to Brad Kammer for the creation of this podcast. We look forward to building community and connection with you and changing the world by transforming trauma.